In the case of People versus Conrad Murray, Dr. Murray is present with his counsel, Mr. Chernoff, Mr. Flanagan, and Mr. Pena. Mr. Gorgian is not present at the present time. The people are represented by Mr. Walgren and Ms. Brazil. Dr. White, once again, is on the witness stand. All 12 jurors and the alternates are present. Everybody, good morning. And to the jurors, good morning and good week. Did we win the lottery over the weekend? Oh, sorry. I'm delighted you're here. Dr. White, good morning. Do you acknowledge, sir, you're still under oath and still sworn to tell the truth?
Yes, I do.
Thank you. This will be cross-examination by the people. Mr. Walgren. Good morning.
Good morning. Thank you, Your Honor.
Thank you.
Morning, Dr. White.
Good morning, Mr. Walgren.
Doctor, you're currently retired from the actual day-to-day practice of medicine?
Yes, I retired in September of last year from my academic position and clinical practice position at the University of Texas.
And how long had you been an actual practicing anesthesiologist prior to your retirement?
Approximately 30 years.
And that was both seeing patients on a regular basis as well as academic field?
Yes, it was clinical care, teaching, and clinical research.
And Dr. White, you would agree that you're an expert in the clinical use of propofol, correct?
I believe I am, yes.
Are you an expert in pharmacokinetic modeling and creating the computer modeling systems and things of that nature?
No, I'm not.
And oftentimes in that area, you may rely on other people, one of which would be Dr. Schaefer, correct?
Yes, I've utilized Dr. Schaefer's expertise in this area in the past, correct.
And you've published a great deal in the area of propofol and the clinical use of propofol, correct?
Yeah, I think over 100 papers.
Dr. Schaefer, you would agree,
Dr. White.
excuse me, Dr. White, would you agree that on June 25th, 2009, Dr. Murray deviated from the standard of care in multiple instances?
Could I ask you for a more specific question? What you say, multiple instances?
Yeah, let me clear it up.
I'm sorry.
Do you agree that there are instances where Dr. Murray deviated from the standard of care in his treatment of Michael Jackson on June 25th, 2009?
Yes, I would.
And would you agree that there are instances where Dr. Murray deviated from the standard of care in the preceding 2 months of treatment as relayed by Dr. Murray in his statement to the police?
Yes, I would.
What is your understanding from reading his interview that Dr. Murray gave to the police regarding what type of propofol amounts were given in the 2 months preceding Michael Jackson's death?
I'm happy to answer your question, but I would like to just preface by indicating that I've had 2 extensive conversations.
Objection, non-responsive. I'm asking you about the interview Conrad Murray gave to the police.
The objection is sustained. The partial answer will be stricken. Disregard. We ask your specific question in its entirety.
Thank you. I'm asking you specifically about Dr. Murray's statement to the police that's in evidence in this trial, okay? And I want to ask you, based on that statement to the police, were you under the understanding from Dr. Murray's statements that he was giving both bolus doses as well as infusion drips to Michael Jackson nearly every night for the prior 2 months?
I think it was about 6 weeks, yes.
In Dr. Murray's statement, he says nearly every night for the prior 2 months, correct?
That's my understanding, yes.
Now, in giving, and you understand, according to Conrad Murray, that he was typically giving 50 milligram bolus doses during that 2-month period prior to running the drip.
Yeah, my understanding is he would give 25 to 50 milligrams mixed in a 10 cc syringe with 5 cc's of lidocaine or 50 milligrams of lidocaine, and sometimes he'd give 1, sometimes 2 injections.
So how would this setup take place based on your demonstration last week? And again, I'm talking, everything I'm asking you is premised on Conrad Murray's statement to the police that's in evidence in this trial. Do you understand that?
Yes, I do.
Okay. So let's assume, based on Conrad Murray's statement, that he was giving 25 to 50 milligram bolus doses followed by an infusion drip for nearly 2 months. How would that take place as far as administering the propofol to Michael Jackson, in your opinion?
Well, again, it's based on what was in that interview. I could not discern exactly how it was actually, the drip was administered. So I would have to rely on some conversations that I've had with Mr. Murray. Dr. Murray, excuse me.
Admonish the witness to reference
It's a
only.
very specific question, Dr. White.
Okay.
The answer is stricken. Disregard the answer, and we'll have a full question and a full answer that's specific to the question.
I just said about 2 questions ago, everything I'm going to be asking you here today regarding Conrad Murray's statements is premised on what's evidence in this trial, which is his statement to the police. Do you understand that?
Yes, I do.
Okay. So is your answer then that you don't know how Conrad Murray administered the drip on prior occasions based on his statement to the police?
I don't know the exact details, yes.
It could have been with 2 separate IV tubing lines as described by Dr. Schaefer, correct?
I guess there are any number of possibilities.
So is that
That's
correct?
one.
Is that correct?
That's possible, yes.
Now, would you agree that in those prior 2 months, administering bolus doses of propofol followed by a drip of propofol throughout the night in that type of bedroom setting would be extremely dangerous?
Without careful bedside monitoring, it could be dangerous, yes.
And with complications could result in death, correct?
If the infusion was somehow became opened up widely and was not carefully controlled, certainly you could achieve a significant effect that could result in cardiorespiratory depression, yes.
Would you ever administer propofol without having access to basic airway equipment, such as oral airway, nasal airway equipment?
I would, when you ask about basic airway, I'm glad you clarified, but I would certainly have a means of ventilating a patient like an ambu bag, not necessarily other types of airway devices, which are nice if they're available, but they're not essential. The main thing is to be able to provide assisted ventilation with a so-called bag and mask.
So would you ever administer propofol to a patient without having airway equipment such as a bag mask available?
I would at least have a bag and mask, correct.
And I assume, have you ever administered propofol in someone's bedroom?
No, I have not.
Have you ever heard of anyone doing that prior to this case?
No, I have not.
When you administer propofol, in your experience, is it in a hospital-type setting where equipment and personnel are available?
Not solely in a hospital setting, most frequently, because I've been associated with university hospitals. I have administered in office and clinic type settings as well as diagnostic and therapeutic centers.
Okay, and I said a hospital type setting where there's equipment and personnel available. Have you always administered it in a setting where there's the appropriate monitoring equipment, resuscitative equipment, and personnel available?
I guess I would need more specifics. I need you to specify what you mean by appropriate. I mean, that's a broad, a broad definition that I would need more specifics, because in certain settings, different type of equipment is available and different type of monitors.
When you administer propofol, do you have available to you, either through other personnel or immediately available to you, airway equipment such as endotracheal tubes and things of that nature?
I believe I've administered in the past in an office practice where we did not have endotracheal tubes or oral airways, but as I mentioned, always at least a bag and mask so I could ventilate the patient.
What about suction apparatus? Is that part of the equipment you think would be necessary for the safe administration of propofol?
I think it's desirable, but it's not, again, it's one of those factors that's certainly available in hospital-based settings, but there are other settings outside the hospital where it may not be available.
But that's a desirable thing to have if you're concerned about not having a patient die, correct?
Well, certainly to treat vomiting, aspiration, it's essential, but that's something that's fairly rare. And again, it would be desirable, yes.
Well, as a doctor administering these types of agents, you prepare for the worst case scenario, don't you?
I don't know what you mean by worst case scenario, but certainly you prepare to treat complications that are likely to occur or possibly to occur. I think you can't have every device available in an office setting, for example, jet ventilation, or there's some situations that arise that may not be covered in every venue in which propofol sedation is administered.
How about pulse oximetry? Is that a necessary component for the safe administration of propofol?
I think pulse oximetry is something that's essential anytime you administer not only propofol, but sedative hypnotics to produce conscious sedation, yes.
How about blood pressure monitoring?
Yes, I think a blood pressure cuff, it doesn't necessarily require an automated blood pressure cuff, but the ability to measure blood pressure, yes.
And how frequently should you measure the blood pressure if someone's being administered propofol?
Again, the frequency would depend on how the propofol is being administered. If you're administering a propofol infusion, for example, we typically would measure blood pressure at 5-minute intervals. However, if you're giving intermittent boluses, small boluses of propofol for minimal sedation, for example, in a diagnostic center, you might measure blood pressure every 15 minutes.
And that would be in a diagnostic center?
Or an office practice somewhere, typically outside of a hospital.
Some type of medical setting, either a medical office, a medical diagnostic center, maybe a surgical suite, a hospital, something of that nature, correct?
Correct.
Now, when you do propofol bolus followed by an infusion, do you utilize electrocardiogram?
Typically, yes.
I mean, that's basically standard equipment, right?
Yes, it's available pretty much.
How about capnography?
I started utilizing capnography early on when we were performing infusions of propofol. It wasn't standard. It still is not utilized in all settings. Most settings outside the hospital don't utilize capnography, but I find it is useful for monitoring respiratory rate. The CO2 values that are actually obtained are not really accurate because they're obtained either at the nose or the mouth, and they're influenced by contamination by air that's coming in and being exhaled. So it's an estimation, and it's largely used in clinical practice for monitoring respiratory rate.
Dr. Schaefer testified that the failure to maintain records or charting or documentation was both an egregious and unconscionable deviation from the standard of care. Do you agree with that?
The terms that you describe, I have to say, are not terms that I'm totally familiar with or use, but I would say that it's desirable certainly to keep a medical record for medical legal reasons so that other physicians can be aware of what was administered to a patient and for purposes of billing. But I don't agree that the lack of a medical record in this case contributed to the death of Michael Jackson, no.
Motion to strike, non-responsive.
Sustained. The answer is stricken. Please disregard.
Do you disagree with Dr. Schaefer's statement that it's an egregious and unconscionable violation not to maintain charting and appropriate medical records?
As I said earlier, I think having a medical record is something that's desirable. It's routinely done. There are reasons for recording a medical record, including medical legal reasons.
I'm sorry, doctor. I was asking you do you disagree with Dr. Schaefer's opinion that the failure to keep medical records in this case was an egregious and unconscionable violation? Do you disagree with that?
As I said, I'm not familiar with what the term egregious and unconscionable implies in this situation.
Do you think that's an extreme deviation from the standard of care to fail to maintain any medical records for a period of treatment going at least 2 months?
I think it's a deviation from the standard of care, yes, but whether it's extreme or egregious, as you said, or unconscionable, I don't agree with, no.
It's not extreme deviation?
I'm sorry, but I don't know how you quantify the degree of severity in this case. I don't think, as I said earlier, which I don't want to repeat because I understand it will. How
would you characterize the deviation from the standard of care as it relates to Conrad Murray's failure to maintain any medical records in this case?
I'm sorry?
Is it minor? Is it serious? Is it extreme?
Well, I would say it's perhaps between minor and serious. It's not extreme, in my opinion. Because
do you maintain medical records in your practice when you were a practicing anesthesiologist?
When I'm in a hospital setting caring for patients, absolutely.
And one of the reasons is it's helpful to be able to go back and analyze your own notes to see how the patient had responded to past treatment or if there are any trends, for example, in the blood pressure readings and things of that nature, correct?
Yes, having old medical records is helpful, particularly if it's a patient you're not familiar with. Previous experiences of physicians can be helpful in your subsequent management. So yes, it can be helpful.
What is the purpose of a pre-procedure assessment prior to administering propofol?
Well, the pre-procedural assessment is to evaluate the patient's overall medical condition, whether they have disease affecting other organ systems that may lead to unusual responses to propofol. It's very important to establish that the patient's medical condition is stable. That is, there's nothing, no recent changes in their medical condition. It's important to establish their airway. Are they at risk to an airway obstruction? For example, obstructive sleep apnea, a short mandible, a short neck, patients that may be morbidly obese. So the airway is very important. To establish any other factor that could accentuate the cardiorespiratory depressant effects of propofol. For example, chronic medications, cardiovascular medications used to treat arrhythmias, hypertension, and similar cardiovascular disorders.
And airway obstruction and cardiorespiratory depression are two of the most common risks associated with propofol. Wouldn't you agree?
I guess it depends. I mean, there are many risks and complications associated with propofol. It causes burning when injected into veins. But certainly the most serious, I wouldn't say the most common by any means, airway problems are fairly unusual with propofol because it, per se, unless you give very large doses or administer a dose very rapidly, it's associated with respiratory stability. Patients generally breathe spontaneously and rarely experience apnea unless it's combined, for example, with an opioid or a narcotic analgesic. In those situations is when we most commonly see the respiratory complications.
Also, other benzodiazepines, of course, correct?
Benzodiazepines tend to have more of an additive effect. Narcotics affect what we call CO2 responsiveness. Normally, when your carbon dioxide level goes up, your ventilation increases. When you have narcotics present, that response is blunted. With sedative hypnotics like propofol and benzodiazepines, they affect more the hypoxic response. That is, as your oxygen saturation declines, your ventilation increases. So that when you combine opioids or narcotics and sedative hypnotics, you get a much greater depressant effect on ventilation because they affect different components of the respiratory drive, if you will, or different arms.
Dr. White, to date, how much have you been paid by the defense for your involvement in this case?
I think I was told I've been paid about $11,000. I got a check recently, which has not been deposited as yet.
And how much do you expect to be paid upon completion of all your work in this case?
I guess if they have money, I think they have limited financial resources.
Objection, non-responsive.
Sustained. The
Motion
answer is stricken. Disregard. Listen carefully to the question. You may ask it, please.
How much do you expect to be paid in total upon completion of your involvement in this case?
Your Honor, that's vague and ambiguous regarding expectations versus actuality.
Well, I'm going to sustain the objection to the characterization expect to be paid. I think you can rephrase the question.
How much do you expect to receive in compensation for your involvement in this case?
That's the same question, Your Honor.
Sustain.
You've received, you have an agreement to receive payment following your testimony in this case?
No, I do not.
Is it your testimony under oath that the only money you're receiving is $11,000?
To date, that's correct. It might be $11,200. I really don't know. My wife handles all my finances.
Is it your testimony that that amount represents the total compensation you are going to receive from the defense for your involvement in this case?
I can't say that with certainty. There are certainly some other expenses, airline trips between Los Angeles and San Francisco that I would hope to be reimbursed for.
Other than reimbursement, for your time, specifically for your time, is it your testimony under oath that the only compensation you're going to receive in total for your time put in this case is $11,000?
I hope I receive some compensation for all the time I've spent in the courtroom.
Okay, and how much compensation are you going to request?
Well, normally, you want to know how much I charge normally for court appearances?
Sure.
About $3,500 a day.
Okay.
But I have not billed them that amount because I don't think they have those resources.
And you've sat here throughout the testimony of Dr. Steinberg, multiple days of Dr. Kamangar. You've been here for hearings. You were here for all of Dr. Schaefer's testimony. I believe you've been here at least 10, 11, 12 days. About that number, does that sound about accurate?
I think that's about right. I think 6 days as an observer. And
that's $3,500 a day for all those days?
I stated that that is what I'm normally paid, but I have not billed them.
Are you going to bill them $3,500 a day for those 12 days, yes or no?
No.
Now, have you ever had a patient stop breathing after you administered propofol?
When I administer propofol for induction of anesthesia, the idea is to get them at a deep level of anesthesia so that you can insert an airway device like a tracheal tube or a laryngeal mask airway, and in those cases, you may see very transient apnea.
Dr. White, I asked, have you ever had a patient stop breathing after you administered propofol? Yes or no?
I guess the answer is yes.
Okay. And what did you do to remedy the situation?
When they stop breathing, I may assist their ventilation with a bag and mask, or I may, if I'm planning to insert an endotracheal tube, I will perform a laryngoscopy and tracheal intubation. If I'm planning to insert a supraglottic device, which is a device that does not go into the trachea, it's just above the glottis, like a laryngeal mask airway or LMA device, I will insert it at that time.
Okay. So you've been able to manage the complication when someone has stopped breathing as a result of a propofol administration, correct?
Yes, as I stated, I always...
You answered the question, thank you. Can you explain for me how you would characterize the doctor-patient relationship?
Well, a doctor-patient relationship involves having a responsibility for a patient, having an understanding of the patient's medical diseases and conditions, and showing compassion for the patient, and doing your best to meet their healthcare needs.
And do you agree that a doctor has a solemn obligation to first do no harm to the patient?
Absolutely.
Do you feel that would you agree that administering propofol in the 2 months prior to Michael Jackson's death violated that oath to do no harm?
As I recall, in the previous 6 weeks, there was no harm. So I guess I would...
So you look at it after the fact, and if the patient's still alive, then the doctor did a good job? Is that how you analyze it?
No, you ask if he did harm to the patient.
No, I said, do you think he violated that oath? The oath being to do no harm.
I think he was providing a service to Mr. Jackson, which he had requested, in fact, insisted on.
He provided a service, correct? That was your word.
I said he provided, well, medical care. Let's choose that as a better word than a service.
That's a better word than the one you used?
Well, it's I think, a more appropriate choice of words, yes.
He was offered money to provide propofol on a nightly basis, correct? Based on Conrad Murray's own interview with the police.
It's my understanding that he wasn't paid any money.
I didn't ask you that, did I? You have to be very closely attentive to my questions, okay? Please, Dr. White.
I will try, thank you.
Conrad Murray was offered money to provide Michael Jackson propofol on a nearly nightly basis, per Conrad Murray's own statement to the police, correct?
I believe that may be correct, yes.
Okay. He was offered money to provide a service, the provision of propofol, correct?
My understanding is he was offered money to be Michael Jackson's private physician and to be essentially, to have Michael Jackson as his sole patient.
Who's the final decision maker when it comes to making medical judgments in the doctor-patient relationship? Is it the patient or the doctor?
I think it's a shared responsibility.
Who's the final decision maker? If there's a conflict in, say the patient requests something that the doctor thinks would be harmful and is not medically indicated, is the doctor supposed to just do whatever the patient says?
Well, the physician always has the option to walk away from the patient. That's correct.
And so you, Dr. White, if you were asked to provide inappropriate medical care that you thought was harmful to the patient, and the patient insisted upon it, would you walk away?
I would never administer what I consider to be inappropriate medical care to any patient.
Okay, so is that answer yes, you would walk away if they insisted upon it?
Yes.
Thank you. Now, why is there a need for the continuous observation of individuals when they're sedated or anesthetized by propofol?
Well, I think a major reason is if you're providing sedation, it's very easy, as we've discussed, to go from one level of sedation to another, either deeper sedation, closer to anesthesia, or lighter sedation. You can also have a situation where the effects are wearing off, and you may have a patient who's wide awake because propofol has a very short duration of effect when you turn it off.
And for that reason, this what you refer to as a continuum of sedation, that's one of the reasons why you need to have constant monitoring of the patient, correct?
When you're administering an infusion or repeated bolus injections, yes, that's correct.
Was it your testimony that if you inject someone, let's say with just 25 milligrams of propofol, is it okay to then just walk out of the room and leave that person alone without any monitoring equipment?
My testimony is that giving a 25 milligram dose of propofol will have minimal effects, lasting less than 15 minutes. So if a patient is observed for 20 or 30 minutes after a single dose, I see no reason why one cannot leave their bedside. As I mentioned, there are studies giving small doses for pre-medication before patients leave a...
Well, and those studies, to be fair and accurate, you don't look at just the dose, you look at the effect on the patient, correct? Because the effect varies from patient to patient, correct?
Absolutely, correct.
Okay, so when you keep saying the dose, you have to also look at the effect. Would you agree?
Yes, and that's why I stated, sir, that you monitor the patient for at least 15 minutes after even a small dose, because this patient, given patient, may have an exaggerated response.
And then after 15 minutes, it's okay to walk out of the room and leave them on their own. Is that your testimony?
I'm saying that if I give a small dose of propofol, that is a minimal sedating dose, 0.4 milligrams per kilogram, and I observed the patient and saw no untoward effect for 15 to 30 minutes is what I said. I said a minimum of 15 minutes, but ideally observe the patient for a half hour. I would see no problem in leaving the patient's bedside.
And that would be in a clinical setting? Medical hospital, office suite, something of that nature, correct?
That's the only setting in which I've given the drug, so
Right.
Yes.
But even in that setting, it's your testimony that you would inject a patient, and I want you to assume they're not hooked up to any monitoring equipment whatsoever. There's no personnel in the room. You would inject them with 25 milligrams of propofol, watch them for 30 minutes, and as they continued to sleep, you would leave them alone without any monitoring equipment or people on hand? Is that what you would do?
In the hospital setting, as we discussed earlier, typically they have an EKG running. They typically have a pulse oximeter on a finger. So I wouldn't characterize it as no monitoring. Having a pulse oximeter in place, it represents monitoring equipment. So.
Well, if you're in the room, if you're out of the room and it doesn't have an alarm, it really doesn't represent anything, does it?
Well, it depends where you can observe. But I think that...
Well, if you can't see it and you're out of the room, a pulse oximeter without an alarm means absolutely nothing. Wouldn't you agree?
I don't agree that it means nothing.
What value does it have if you're out of the room, you can't see it, and it has no audible alarm, and no one else is there? What value does a pulse oximeter have with no alarm?
Well, if you've observed the patient for a period of time and the pulse oximetry value, the saturation is stable, we know that propofol in a 25 milligram dose will have effects that last maybe 5 minutes, maybe 7.5 minutes, and beyond that, virtually no effects. So if you've observed them for 25 or 30 minutes, I think you can certainly move away from the bedside.
Okay, that wasn't my question. My question is, I'm asking about a pulse oximeter without an alarm. If you are not there to see it, to see the little tiny screen, and you're not there to hear it, it doesn't even have an alarm, what value does it serve?
Well, only
In your absence, what value does it serve in your absence?
in your absence, it probably has little, if any, value.
None, correct?
Well, yeah, that's true.
Okay, it has no value, correct? If you're not in the room. Correct?
Correct, yeah.
Thank you. And 25 milligrams of propofol, which you keep referencing, of course, assumes no other benzodiazepines are on board, right?
It certainly no acutely administered benzodiazepines. If they've been administered hours before, they would probably have very little, if any, effect.
But they could have an effect.
They could have an effect dependent on the time interval between the administration of the last dose of the benzodiazepine and the dose, a small dose of propofol.
Well, would that influence, if you knew that a patient had, and I'm talking about you personally, if you knew a patient had lorazepam and midazolam on board, and you gave 25 milligrams of propofol, would you still just walk out of the room after observing them for 15 to 30 minutes? Or would that be something that would raise your awareness to maybe pay a bit more attention?
I still feel that that is adequate, in particular if the 25 milligrams of propofol is administered over 3 to 5 minutes, very, very slowly. That represents a very slow dose that would not be expected to achieve a very high peak level.
So you, again, my question was, would you, knowing that benzodiazepines were on board and you administered 25 milligrams and the person had not woken in your 15 to 30 minutes of observation, would you be comfortable then leaving them alone without any monitoring equipment? Yes or no?
I said it depends on the time interval between the last dose of midazolam and the slow bolus injection of propofol.
So would the fact that you knew benzodiazepines were on board in any amount alter your level of care?
I would certainly observe the patient carefully as I would even if it was just propofol alone.
But just for 30 minutes?
I think 30 minutes is certainly adequate for a slow 25 milligram bolus dose of propofol, even in a patient who has hours earlier received a small dose of midazolam or lorazepam, yes.
And that would be the acceptable standard of care, to administer midazolam and lorazepam and 25 milligrams of propofol, and with the patient not being hooked up to any monitoring whatsoever and no staff on board, it would be appropriate for you to walk out after 30 minutes. Is that your testimony?
Are you asking me about the standard of care or the standard practice?
I'm asking about the standard of care. Would you, and I'm asking about you personally.
Well, the standard of care is the ultimate or most ideal standard of care. And obviously, the standard of care would require monitoring, as I've suggested earlier.
Okay, so is that then that you would not leave that patient alone without any monitoring or any staff to make sure that they're safe? You would not do that? Is that correct?
I would observe the patient for a period of time. If this was an unusual case because the doctor was trying to achieve allow the patient to achieve a sleep state. So I think that once the patient was resting apparently comfortably and had been observed for a period of time such that the risk of either respiratory or cardiovascular adverse effects had passed, it's not unreasonable to leave. It certainly is done in practice if you're giving a small dose on a one-time basis. It's quite different than a situation where you're giving an infusion or repeated doses. Then it would absolutely be unacceptable.
What if in your mind you had previously made statements that the patient likes to push the propofol themselves? Would that change your willingness to just simply walk out of the room and leave them alone with no monitoring?
It would certainly make me careful about allowing access to drugs.
Would you walk out of the room and leave them alone with no personnel and no monitoring if you were of the opinion they like to push propofol themselves? Would you walk out of the room in that situation, yes or no?
No, I would not leave the room.
Thank you. You can't justify Conrad Murray's failure to call 911 in the period of time, or in the waiting essentially 20 minutes to call 911, can you?
No, I cannot.
That's an extreme deviation from the standard of care, wouldn't you agree?
Again, these classifications are not familiar with me. I would say that given the fact that Dr. Murray is a cardiologist who is certified in advanced cardiopulmonary life support.
Objection assumes facts, not in evidence.
Overruled. You may finish your answer.
Did he act like someone who was well-skilled in advanced cardiac life support? Did he act like that?
I was not present to make that assessment, sir.
You've taken all his statements as true in your assessment, correct?
I wouldn't necessarily say I've taken all his statements as true, no.
Do you think from your review of his statement to the police that he acted like someone who was well-skilled in advanced cardiac life support?
I think Dr. Murray, upon returning to Michael Jackson's bedside and finding him apparently in full cardiopulmonary arrest, probably reacted as many physicians would. He was very probably anxious, and in those situations, it's very stressful for anyone, even someone who is ACLS certified.
So is that no? He did not act as a well-skilled person trained in advanced cardiac life support?
I didn't say that, sir.
Okay, well, I asked the question, and I'll ask it again. Did Conrad Murray, in your opinion, based on his statements to the police, act like someone well-skilled and well-trained in advanced cardiac life support?
I can't make that assessment. I would have done things differently in terms of calling for help and in terms of calling 911.
What would you have done?
Immediately, I would have called for help, although I understand this was sort of an isolated area, and there was, it was...
Isolated area?
Of the house, yes. I understand it was a special suite of rooms on...
There was a bedroom upstairs.
Yeah, but
okay.
Remove...
What would you have done? That was my question. What would you have done? You said you would have called for help.
I'd have called for help. I would have assessed the patient, initiated cardiopulmonary resuscitation immediately.
And after making an assessment and starting cardiopulmonary resuscitation, if you were in that situation and you knew you had no personnel on hand and none of the resuscitation equipment, wouldn't you call 911?
Yes, I would call 911.
Okay.
But my understanding, if I may, is that this was an unusual situation because this was a house that had a secure perimeter and had no phone lines in the house. So it's not a typical situation where you can call 911 and have immediate access to the premises.
I would certainly agree this was an unusual situation, but Conrad Murray had a cell phone in his hand by his own statement and used it to call Michael Amir Williams. Are you saying he was not capable of pushing 911, maybe putting the phone down on speakerphone and continuing with the cardiopulmonary resuscitation?
It's my understanding that, number one...
I'm asking your opinion.
Okay, my opinion...
About what you would do. There was a cell phone. Conrad Murray used it to call Michael Amir Williams. If you were in that situation, you come on the patient, and he's in full cardiopulmonary arrest, and you assess the patient, and you start resuscitative efforts, and you've called for help, wouldn't you use that cell phone to call 911 as quickly as possible?
Yes, but in calling 911, you need to know the address. You would need to be able to make sure they could access the premises. And my understanding is...
So is it your testimony, because there was a gate around the house, that excuses Conrad Murray not calling 911? Is that your testimony? Because you've mentioned this gate a couple times now.
No, it doesn't. It doesn't at all.
Then we can set aside the gate, right? Because that has no bearing on Conrad Murray's need to call 911 as soon as possible, correct?
Well, I think that's the reason he called the security individual, Michael Amir, to inform him that he needed emergency medical assistance.
Okay. And you realize when he called Michael Amir Williams, he didn't tell Michael Amir Williams to summon emergency medical assistance. You do realize that, don't you?
If that's what you say, yes.
Okay. Wouldn't you agree that it's much quicker to call 911 than to call someone's personal cell phone number, have it ring through to voicemail, and then leave a message on that voicemail? Wouldn't you think it would be much quicker to simply call 911 and even put the phone on speakerphone and continue with your resuscitation? Wouldn't you agree with that?
Well, you can have people on speed dial and call them even faster than 911, so I think certainly 911 is easy to dial. You're absolutely right.
There's no justification for what Conrad Murray did in failing to immediately call 911, is there?
As I said earlier, I think he should have called 911 sooner. I do not, however, think it would have made any difference in the outcome of this case.
Now, you commented, let's strike that. After if you personally came upon Michael Jackson in that state where a pulse was felt, and you assessed the patient and you started resuscitative efforts, how long would it take you to decide in that setting, in a bedroom in a home, that you needed to call 911?
Are you saying if I felt a pulse?
Well, Conrad Murray said he felt a pulse, yes, so that's what I'm saying.
He said he felt a thready pulse.
He said he checked the pulse oximeter, and it read 122, and then he felt the femoral pulse, and he felt a thready pulse, correct. In that situation, if you came upon those facts, how long would it take you to decide that you should call 911?
Well, again, if I came upon that situation and I was ACLS certified and a cardiologist, I would immediately start resuscitating the patient and call 911 shortly thereafter.
What's shortly thereafter?
3 to 5 minutes, I would guess, if you ask me for a number.
In this type of situation where paramedics are eventually called and they arrive on the scene, doesn't a doctor have a moral and ethical obligation to reveal all medicines to that responding emergency personnel that have been given to the patient that could affect the treatment?
I think in general we try to recount all the events, but in an emergency situation, as happens in hospital environments as well, it's often difficult to recall details in that kind of situation.
Is it your testimony that the failure to mention propofol to the paramedics was an inability to recall details? Is that your testimony, Dr. White?
Well, I'm just saying details can be overlooked. I'm not saying it's appropriate, but I don't think it was done in a devious fashion.
You think, so I just want to be clear, you think it was just a detail that was overlooked when Conrad Murray failed to advise paramedics he had been administering propofol? Is that your testimony? There was a detail that was overlooked?
I don't think I used those words. Propofol, a small dose of propofol could not be reversed. It's not like benzodiazepine.
Do you understand my question to ask you if propofol could be reversed? Is that how you construed my question? Is that how you construed my question?
No.
Okay, then please listen to the question and please try to answer my question. Is it your testimony that Conrad Murray's failure to inform the paramedics that he had administered propofol was simply a detail that had been overlooked? Is that your testimony?
I think it was something that he overlooked.
Okay.
Yes.
Having time to ponder it and think about it and ride along in the paramedic's vehicle while Michael Jackson lay on a gurney, and then arriving at UCLA, was it still then another detail that he overlooked at UCLA when the emergency room doctor specifically asked him what had taken place? Is that your testimony, that that again was a detail that was overlooked?
Well, it was obviously overlooked. He didn't tell them.
Well, not obviously. It could also be a lie, correct? Correct? That's another option.
If you say so, I guess, yeah.
That's another option, correct?
It's an option, yes.
Thank you. Now, you said in your report, Dr. White, that in your opinion this was, as you said here today, cardiopulmonary arrest, and you characterized it as that the central nervous system depressant effects of this combination of medications can produce significant ventilatory depressant effects as well as upper airway obstruction, parentheses, due to relaxation of the pharyngeal musculature, correct?
You mentioned a report. I didn't actually write a report. I wrote a letter. Are you referring to the letter to Mr. Flanagan?
This is the only thing I was ever given, so whatever you want to call it. This 3.5-page document was the only thing I ever received from you. You want to call this a letter or a report?
It was a letter.
Okay, this is the only thing I have. So this was what documents your findings, correct?
No, not at all.
Is there some other information, reports you've given to the defense that you didn't provide to me?
Not in writing, no. But I've certainly conveyed my evaluation of materials to the counsel over the phone and in personal conversation.
What do you want to refer to this as, a letter or a report?
I think it's a letter.
Containing your findings at the time regarding this case, correct?
It contains some preliminary thoughts on this case, yes.
And this is the only document you've ever provided, is a document that contains preliminary thoughts?
Correct.
And in this letter containing your preliminary thoughts, you state that it was likely acute cardiopulmonary arrest where the central nervous system depressant effects of this combination of medications can produce significant ventilatory depressant effects as well as upper airway obstruction, correct?
I don't have the document before me, but it sounds like something I may have written, yes.
Would you agree that the risk of adverse drug reactions increases when combinations of sedative and analgesic drugs are administered?
When combinations of sedative and analgesic drugs are administered, yes, I would.
And that the potential for compromising the respiratory system results from depression of esophageal and laryngeal reflexes, upper airway obstruction, and depression of central hypercarbic and hypoxic ventilator responses. Would you agree with that statement?
Correct.
And although benzodiazepines may be used as an appropriate, procedure of sedation or anesthesia, you're well aware of the contributory effect that these drugs can have, and that it increases potentially the dangers of what is being administered. Would you agree with that?
You were earlier referring to sedative analgesic. That's very different than just talking about sedatives. I'm not aware of studies that have looked at the effects of prior benzodiazepine administration on ventilatory response to propofol, for example.
Is it your testimony that the prior administration of, for example, lorazepam and midazolam, is it your testimony that does not increase the risk in any way to respiratory failure?
As I stated earlier, it depends on the time interval following their administration when...
So there is a risk, but it depends on other factors, but there is a risk, correct?
There's potentially a risk,
Okay.
but it's only theoretical, and it depends on, or it assumes that that time interval is fairly short and the blood levels of the benzodiazepine are high.
You said it's a theoretical risk, but you opined on Friday that because, in your opinion, Michael Jackson swallowed lorazepam pills and then quickly injected propofol, that he essentially killed himself, correct?
I suggested that one of the possibilities is that there was a high concentration of lorazepam, which I believe was measured at autopsy, and if one then administered very rapidly propofol, you could achieve a cardiorespiratory arrest. Certainly, an arrhythmia could occur, and this could result in very rapid demise of a patient.
Who's responsible for bringing propofol into Michael Jackson's home, in your opinion?
Well, Conrad Murray certainly purchased propofol, but I understand Mr. Jackson had his own supply as well.
Really?
Correct.
Where is that in the police interview by Conrad Murray?
Well, I had heard that...
Objection.
Okay.
Non-responsive. Where is that in the
Just a
police
moment,
interview?
please. Sustained. The last partial answer stricken.
You keep throwing out these kind of rehearsed lines, I think. My question is, where is that?
Just a moment, please.
Objection, this argument.
Sustained.
Please,
Ask a proper question. Thank you.
where in Conrad Murray's statement to the police is that reflected?
I don't have the report in front of me. I reviewed it in February, and as I indicated, I've had two lengthy
Objection,
conversations.
motion to strike. Would the court admonish the witness?
The objection is sustained. The answer stricken. Disregard, please. May I ask a favor, ladies and gentlemen, if you could just leave us for a few moments, please? Remember the admonishments. Don't get too comfy. I'm just going to ask that you go into the jury room. Thank you.